Good evening, everyone. Thank you for joining us. Please join me in welcoming Dr. Bowen this evening. Dr. Bowen is an associate professor of urology at the University of Oklahoma Health Sciences Center, specializing in the minimally invasive treatment of urologic issues and men's sexual health. He is a board-certified urologist and has practiced in Edmonds since 2012. His medical education and training were both at Tulane University in New Orleans. His urologic training was focused on kidney stones, robotic surgery, infertility, and erectile dysfunction. Dr. Bowen has published multiple articles in peer-reviewed urologic journals and has lectured at state and national meetings. He is also a member of the American Urologic Association, the Indo-Urological Society, and Sexual Medicine Society of North America. Dr. Bowen, welcome, and thank you for being here this evening. At this time, I will turn the presentation over to you.
Thank you, Jessica, and welcome to all you all who are watching this live or the recorded version. We appreciate you taking your time to learn more about erectile dysfunction and treatment options for stress urinary incontinence in men. We'll take you through the signs and symptoms of ED, as well as the multitude of treatment options, including curative therapy, such as penile implants. So for erectile dysfunction, we'll talk about what is it, who has it, what causes it, and how we can treat it. So what is erectile dysfunction? So erectile dysfunction is the inability to achieve an erection or maintain that erection through the completion of intercourse and orgasm. What ED is not is being able to maintain an erection for more than 30 minutes and have multiple orgasms. So inability to achieve or maintain an erection firm enough to have sexual intercourse. And a lot of guys ask, how common is it? You know, am I the only one that has it? Well, you certainly, or most certainly are not the only one that has it. 1 in 5 Americans over the age of 20 have ED, and half of the men over the age of 50 have some degree of ED. The older you get, the more likely you are to have ED and the more likely it is to be severe. 39 million men in America have some amount of erectile dysfunction. So how does one get an erection? So when aroused, the nerves surrounding the penis become active and the muscles around the arteries begin to relax and more blood flows into the penis. And as that blood flows into the penis, it gets stiffer and harder and erect. And as the penis fills up, it compresses the veins so the blood can't leave the penis, enabling the penis to maintain erection. So you need 3 things to have a good erection: good nerve supply, good artery supply, and be able to compress those veins to keep the blood inside the penis. So what can cause erectile dysfunction? Well, erectile dysfunction correlates positively with poor health. So if you're in pretty good shape, no diabetes, no high blood pressure, no prostate cancer, no heart disease, your chances of having ED, especially at a young age, are rare. However, ED can happen whether you have these or have no issue whatsoever. But as you can see, the most common causes are vascular causes, diabetes, and medications. Common blood pressure medications can certainly result in erectile dysfunction. We're going to get into prostate cancer, diabetes, and heart disease in detail. So erectile dysfunction and diabetes. 15.5 million men have diabetes in the US. 1 in 2 men with diabetes have sexual troubles related to their diabetes. In men with ED and diabetes, usually that ED is more severe and less likely to respond to oral medications. And ED occurs 10 to 15 years earlier in men with diabetes than men without. Diabetes and related conditions can damage the nerves as well as the tissues associated with achieving and maintaining erections, such as the arteries and veins. 60 to 70% of people with diabetes have nerve damage or neuropathy, which can certainly affect the initiation of an erection. And diabetes accelerates the endothelial dysfunction, or the dysfunction that happens inside the blood vessel, to maintain an erection. Oral medications require sexual stimulation with nerves and require good blood flow. If damaged from diabetes, the pills just aren't as effective as they would be in other men. Erectile dysfunction and heart disease. So sometimes the penis can be the canary in the coal mine or the heart's barometer. Erectile dysfunction can be a warning sign of future heart disease. On average, symptoms of heart disease will develop within 2 to 3 years of the onset of ED. And within 3 to 5 years of ED, a cardiovascular event such as a heart attack or a stroke may be more likely to occur. In men that have heart disease, have their first heart attack, 70% had ED that was going on before that. So that was the check engine light that was going off, letting you know that it was time to get checked out. And unfortunately, a lot of men think that's just a natural part of aging and don't get a full evaluation. And that can be a big mistake. So why is the penis the heart's barometer? And you can see in this picture, the penile artery is right here, about 1 to 2 millimeters in inner diameter, versus the main artery that supplies the heart is about 3 to 4 millimeters. So it's about twice the size. And so if you have poor blood flow to the penis, the next step is to have poor blood flow to the heart, which causes heart attacks. The artery that goes to the brain that can cause strokes is slightly bigger than the heart. And the leg pain associated with walking, where you get pain in the calves when you walk a long part of the distance, that can be one of the last signs of poor blood flow. So you want to catch vascular disease in the erectile dysfunction phase, rather than waiting until it becomes a sudden heart attack or chest pain. So what about erectile dysfunction and prostate cancer treatment? Prostate cancer is the most common solid organ malignancy or cancer in men. The nerves that supply stimulation for the erection and the prostate lie right next to each other. You can see here in the picture, these are the nerves right here that supply the prostate as well as the erection. And when the prostate's removed, you have to try and gently push those nerves off the prostate and spare them. But even despite best efforts to spare them, it can still affect erectile dysfunction. And sometimes that's temporary. Most men that are going to see their erections come back are going to come back within about 1 year of surgery. And some men, if their erectile dysfunction is still not back after a year, it can become permanent. So in men with prostate cancer treatment, erectile dysfunction affects 25 to 75% of men. In men who have surgery, including robotic surgery, 10 to 46% of men still have ED 1 year after surgery. And despite what we may hear on the radiation and proton ads on TV, sexual dysfunction affects up to 50% of men who have radiation or proton therapy associated with their prostate cancer treatment. So that's what causes ED. The next thing we'll talk about is the smorgasbord of treatment options available for erectile dysfunction in 2020. The main options that we'll talk about are oral medications, injection therapy. This is the $99 solution you hear about on sports radio. Penile implants, which is the only curative therapy for erectile dysfunction, vacuum devices, and urethral suppositories. So oral medications, these are your PDE5 inhibitors, Viagra, Cialis, Sildenafil, Stendra, all available by prescription. How do they work? They increase the blood flow to the penis. Basically, the drugs make the arteries work better. So it increases the blood flow, which leads to increased ability to achieve and maintain erection. They do require sexual stimulation. They do require nerve supply to work. You take them up to an hour before sexual activity, and the typical peak time is from 1 hour to 4 hours after you've taken it. You can only take it once a day, and Viagra especially can be affected by food. So we generally recommend when you're using Viagra to take it at least 2 hours after your last meal and 1 hour before sexual intercourse. Cialis has no effect with food, and so it can be taken at any time. Both Cialis has been shown to be safe with alcohol, but obviously alcohol can impair the performance of the medication and the penis. How effective are the medications? Well, they work pretty good. When these came out, it was a game changer. It was effective in approximately 50 to 85% of cases. One of the things, especially in men with prostate surgery, is half the men gave up on their erections if the pills stopped working. So if you learn anything today, it's that if the pills don't work, we have other options available, including options to cure your ED. So don't give up if the pills don't work, because again, in up to half the cases, the pills may not work. Men with diabetes are 1.5 to 2 times more likely to move on to other treatments if the pills don't work. One of the things you should know, certainly I practiced through the time when, patients were paying $30 for Cialis. Those days are far behind us. The days of having to go to Canada or Mexico to get overseas oral medication, those days are behind us too. Both Cialis and Viagra have gone generic, and you can typically get 5 pills for less than $15 using the GoodRx program with either one, whichever one you prefer. The side effects of each one are a little different, but Viagra and Cialis are equally effective. One is not more effective than the other. Common side effects associated with medications: headache, facial flushing, stuffy nose, upset stomach, backaches with Cialis, blue halos with Viagra. Some cautions: talk to your doctor if sex is inadvisable because of your cardiovascular status. That's usually in men with either unstable angina, recent heart attack within the last 3 months, or severe congestive heart failure. With alpha blockers, you should be on a stable dose, and you should try and take your Flomax or your terazosin or doxazosin at least 4 hours apart from your Viagra or your Cialis. With nitrates, talk to your doctor. Nitrates cannot be safely taken with PDE5. So if you use a nitro paste or an Isodur pill or isosorbide pill, or if you need the occasional nitroglycerin for chest pain, it is not safe to take the oral medications. And certainly you would be involved with a cardiologist if we got to that point. Tell your doctor if you ever had any heart problems, stroke, low or high blood pressure, if you have any liver or kidney problems. These are generally recognized before we start the medications. Vacuum erection device. These have been around for many years. It's a hollow plastic tube. It's placed over the penis. The pump can be hand powered or battery powered. It uses negative flow or negative pressure, such it creates a vacuum over the penile shaft, and that pulls blood from inside the body into the penis. And then there is a constrictive band that is initially on the plastic tube, and you slide it off, and it holds the blood inside the penis. The erection band can be placed on the penis for about 30 minutes. You can't leave the band on longer than 30 minutes. It's generally pretty effective. It works 65–80% of the time. However, men that have used a vacuum, only about 1 in 4 are still using it after a year. So many men move on to other options. I generally recommend the vacuum device for your birthday and anniversary crowd. if you and your wife only want intimacy once a month, maybe once every other month, the vacuum erection device might be a good solution for you. If you and your partner's goals are to get back to intimacy a couple of times a week, you're not going to be happy long-term with the vacuum. So side effects of vacuum device: it can block ejaculation, cause bruising of the penis, penile discomfort, penile numbness or coldness. Most common reasons why people stop using the vacuum device: erections are insufficient with rigidity or duration. They have difficulty with the mechanics, especially getting that penile ring over the top of the cylinder. Penile bruising and lack of spontaneity. You know, if you go on vacation, you got to take it with you, and when you're in the mood, you got to stop, take a break. You know, wait 15 minutes to get the vacuum, find the vacuum, put it on, get everything situated. Urethral suppositories. These are really on here for historical purposes. It's important to know about, but these are rarely used in 2020. Muse is the brand name. We use these quite a bit during residency. It's a suppository that must remain refrigerated. It's inserted into the tip of the penis, and then it's rubbed into the urethra to absorb. And the medication is absorbed into the urethra and goes into the penis and causes blood flow dilation. Success rates are only about 40 to 65%. 40 to 50% of men won't continue using it. The most common reason why is pain in the penis or urethra. It's usually a burning sensation in the tip of the penis. It's not very pleasant. The other reason, it's not listed here, but the other reason why this is rarely used is the cost. The cost of dosing for this is $75 to $150 a dose. And that's cost prohibitive for almost everybody but Bill Gates and Mr. Cook at Apple. So intracavernosal injections, these are quite common. This is the guaranteed $99 office solution you hear about on the radio. It's usually a compounded medication, although name brand medications are out there. They inject the medication directly into the side of the penis, usually 5 to 20 minutes before you want to be intimate. So it does have a pretty quick onset. It works 60, 70% of the time. Despite success, only 20% continue the therapy over a year. Most common complaint being penile pain at the injection site, or it doesn't work. One of the true side effects of these injections that, everybody kind of snickers at the Viagra and Cialis commercials when they talk about erections lasting longer than 4 hours. Well, that really never happens with the pills, especially in men who have been prescribed the medication. But that can happen with these shots. So generally we tell our men, if they have a painful erection for longer than 2 hours, they need to either come into the clinic or come into the emergency room to get an antidote to the injections. The other thing that's really important to know about the injections is 5% of men who use the injections will develop scar tissue on the penis. And that can have two major effects that are really important. One is penile shortening, and the other is penile curvature, which can make it impossible to penetrate if you have too much curvature on the penis. Most common reasons why people quit: unsatisfactory erections and pain. The needles that we use are really small, the same needles that diabetics use for insulin injections. They're tiny, tiny needles. And finally, what we're here to talk about is the penile implant. One thing I tell my patients is, do you want to treat your erectile dysfunction, or do you want to cure your erectile dysfunction? And, there's no wrong answer. It's whatever works for you. But if you want to cure your erectile dysfunction and you failed medications, you really need to take a hard look at the penile implant. So how does the penile implant work? It's an outpatient procedure, one night stay in the hospital. It's a pair of inflatable cylinders that are implanted on the inside of the penis and inside the scrotum that works by squeezing and releasing a pump that's hidden inside the scrotum. The device can be inflated with 7 or 8 squeezes, and it can be deflated with the press of a button. How effective is it? Well, 98% of patients reported erections to be excellent or satisfactory. 7 years, 94% of men still use their device and have been free from any subsequent surgeries. The most common side effects include postoperative genital pain. Very few of patients require any pain medicine beyond a week. I'd say probably half our patients now, when they go home, they don't take any pain medication. Mechanical malfunction or autoinflation is rare, less than 5%. Infection with the antibiotic-coated devices and all the precautions we take before and during surgery, as well as after surgery, have really minimized that down to about 2% or less. And here's a quick animation of how the penile implant works. So, one of the things people ask is, will anybody know I have it? The penile implant is completely hidden inside of your body. It can be done with a small incision in the front side of the scrotum, but here you go. Here is the control pump that's hidden completely inside the scrotum. He's using his fingers to squeeze and inflate the device, takes fluid from the reservoir and fills the penile cylinders. And these cylinders are customized to your penis size. And then you hit the release button and the penis will deflate. Usually you have to give it a squeeze to get it, fully deflated quickly. Generally, it's an overnight stay in the hospital, a follow-up at 3 weeks. If everything looks good, we have you start inflating and deflating for an hour every day. And at 6 weeks, you're ready to go. You have a reliable, straight penis that is hard anytime you want it, after 6 weeks after the procedure. So it's a permanent solution or a cure to erectile dysfunction. It's spontaneous. Wherever you go, it goes. If you go on vacation, your penile implant comes with you. When you're ready to have sex, 7 quick squeezes and you have a hard erection that can last as long as you want. So there's no 30-minute window. There's no till the medicine wears off or the shock wears off. It stays up as long as you and your partner desire. It's entirely contained inside the body. No one knows you have it but you. A high patient and partner satisfaction. 90% of partners were pleased their husband went through it. A lot of guys we see, they'll come in and say, "Oh, my wife wouldn't want me to do that." Well, she wouldn't want you to feel obligated to do that. But I think if you ask for her support, she would give it. Okay. The penile implant does not interfere with ejaculation or orgasm, as well as penile sensation. Implants have been in use for more than 40 years. 500,000 penile implants men have been treated with the penile implant. Penile implants are not without risk, but we take a lot of steps to mitigate that risk. Not all patients are candidate for a penile implant, but the vast majority are. Once you go the penile implant route, you can't go back to injections or pills. So once you get to the penile implant, you're committed to it. The good news is, it's gonna last you for a long period of time, 10 plus years. If you're in one of the 5 or 10% that have a mechanical problem over 10 years, the implant can be removed and completely replaced, again, as a simple outpatient surgery. Pain, again, is typically temporary, less than a few weeks. Men with diabetes and spinal cord injuries may be at slightly higher risk of infection. Any man with diabetes who elects to go a penile implant, we would want their A1C to be under 10. So ED is a common problem. Don't think you're by yourself. There are a variety of treatment options, some of which may be new, and they have different pros and cons to each one. Penile implants are a permanent solution. Talk to your wife. She may tell you that you don't have to do that for her, but I will tell you, most of the wives that come back into my office, the vast majority come back into the office, and we're glad they made the right decision. Talk to me or talk to a prosthetic urologist. Not every urologist does penile implants. So if you have a urologist or a primary care doctor that's not familiar, you may want to talk to somebody with specialty training in prosthetic urology. And you can find one or at edcure.org, or you can certainly contact me. All right, that concludes the erectile dysfunction. The next topic up for discussion is understanding male stress incontinence. So there are typically three types of incontinence in men. Stress incontinence is leakage with activity or leakage with cough and sneeze, getting out of the chair and having leakage. And it's almost in men, almost exclusively associated with prostate surgery. So radical prostatectomy for prostate cancer, and then certain BPH operations such as holmium laser enucleation of the prostate, HOLEP, or TURP have been associated with this issue. So that's what we're going to talk about today. Other types of incontinence that men may experience include urge incontinence. That's when you have to go to the bathroom and can't make it in time, or overflow incontinence, where your bladder is just so full it overspills, and that's usually related to an enlarged prostate. So male stress urinary incontinence, what is it, who has it, and what causes it? What is it? It's bladder leakage. Stress incontinence is when the urinary sphincter muscle is damaged or weakened and cannot squeeze and stop urine flow from flowing out of the body with laugh, lift, walk, bend, push, pull, or move. How prevalent is it? 50% of men report leakage immediately following surgery, but most heal within the first few weeks to months. 9 to 16% of men will have stress incontinence that lasts beyond a year. And these are the men that need to start thinking about a surgical intervention to treat their ED. The other men, if you've had persistent stress incontinence that has not improved over the last 6 months. So if, the day after you get your catheter out, after your prostate procedure, you're at 4 pads a day, and at 6 months after you're still at 4 pads a day, you may be a candidate for treatment, surgical treatment at that point. But otherwise, if you have leakage beyond a year, you are certainly a candidate for surgical treatment. 500,000 men worldwide suffer from male stress incontinence. So how does the urinary process work? The bladder stores the urine. Urine exits the body through the prostatic urethra into the bulbar urethra and out the end of the penis. The sphincter muscle is right here, right at the front edge of the prostate. And when the sphincter muscle relaxes, the bladder muscle contracts and the urine leaves the body. Stress urinary incontinence in men is strongly correlated with prostate cancer surgery. 9 to 16% of men have persistent post-prostatectomy incontinence 1 year after treatment. It can also be the result of neurologic disorders, BPH surgery, external beam radiation, and pelvic trauma. So what are the treatment options available for male stress incontinence? 181,000 men are diagnosed with prostate cancer each year in the US. Approximately 70,000 radical prostatectomies are performed each year. The radical prostatectomy is the operation to remove the prostate and its surrounding tissue. And then 9 to 16% of men will have leakage that lasts beyond a year after their prostatectomy. So a side effect of prostate cancer treatment, incontinence is normal immediately following the prostate surgery, but incontinence is often restored during the first year of recovery, but not all patients regain their continence. There are many solutions for men who want to restore their continence and get back to their normal life. So the first thing we recommend for all men who present with this issue after prostatectomy are behavioral modifications. So reduce your fluid, especially when you're going to be active. Make planned restroom breaks. You know, a lot of guys, as they're about to reach that continent stage, they notice that they only leak when their bladder's really full. So men may, take a restroom break every 2 to 3 hours to prevent their bladder from getting super full and making them more prone to leakage. But that's usually at the back end when you're almost there, recovered from surgery. The main intervention that we ask people to do after prostate cancer surgery is Kegel exercises. And that's not contracting the butt cheeks, but contracting the butthole, okay? Squeezing and holding that muscle as long as you can, and then relax. You should feel that in your penis. You should feel that penis elevate up when that pelvic floor muscle contracts. So squeeze the butthole, hold it for as long as you can, and relax. And you want to do 3 sets of 15 every day. If you're having trouble, not sure you're making the right moves, biofeedback and physical therapy can certainly help with that. And then there's coping, which it's sad that a lot of men think this is their only option. Coping includes pads, diapers, catheters, penile clamps, when there are other solutions that, sort of get your dignity back for the treatment of post-prostatectomy urinary incontinence. So the 2 big options here for this issue are the male sling and the artificial urinary sphincter. The male sling is designed to support the urethra, so it kind of acts like a backstop. When you cough or sneeze, the urethra hits the sling and compresses the urethra. It's most appropriate for mild to moderate stress incontinence, and those are generally, in my experience, the 2 pad a day or less guys. It's made of a soft mesh material, completely concealed within the body. It's a outpatient procedure. It's generally pretty effective, 60–80% in that 2 pad a day or less group. And then you have the artificial urinary sphincter, and the AUS is designed to replicate the function of the external sphincter. So it's essentially a full replacement. And it can treat all levels of stress incontinence, from 10 to 20 pad a day guys, which are very rare, all the way down to the 2 pad or less group. It's made from 3 small components that are interconnected inside the body. And just like the penile implant, completely concealed. So no one knows you have it but you. The male sling is minimally invasive. You can typically get back to your normal activities in 1 to 2 weeks. There's no interaction with the device. So once you put the sling in, if it works, it's going to work. And it can help restore normalcy and renew continence, renew confidence. I think one of the barriers that, people sort of subconsciously, they withdraw a little bit from social activities because of this issue. They don't want to take their pad, or they're concerned about the smell of urine. And the male sling is, for that guy that's still 2 pads a day, a year after surgery, and wants to be done with pads. So that's who is a good candidate for the male sling. The artificial urinary sphincter mimics the healthy urinary sphincter. It allows you to urinate when desired. It can be used for most men with weakened sphincter and inability to achieve continence. It's placed entirely inside the body, but it does require activation every time you use the restroom. So this is a quick animation of how the device works. It It is usually done with 2 small incisions, one behind the scrotum and one just above the penis. And here is the control pump, and we put it on whatever handed side you are. So if you're right-handed, it goes on the right. If you're left-handed, it goes on the left. You give the device a quick squeeze, it opens up the cuff. After about 30 seconds, the back pressure of the balloon refills the cuff and closes the urethra. So take control of your condition. If you're bothered by your leakage, take action and restore your normalcy. One of the things that, I see, I treat both men and women in my practice. And when you see women who've had gone through breast cancer surgery, it's completely expected that they get a reconstruction. They have the mastectomy, they get a reconstruction, they get an implant, a tattooed nipple. It's all part of the package. If to restore your ability to have intimate contact with confidence. Men don't seem to think that they deserve that, and that's just wrong. After you've had prostate cancer, you are not sentenced to leakage or erectile dysfunction. You are entitled to become dry and to become potent. And you should feel that that is just part of the normal process, that gets restored. And that's not the price you pay for surviving prostate cancer. I think that's really important that some men miss. So what can you do to take action? Speak with your urologist. Know what your daily pad usage is. And, keeping a weekly pad journal is helpful. I just really want to know on average how many pads a day you're using. And then you demonstrate your leakage in the office. And that's really all we need to know to get you on the right track to get this fixed. There are risks to the sling and the artificial sphincter, just like any procedure. With male sling, the biggest risk is device failure. So again, in 20 to 30% of men, the sling may not work despite having 2 pad a day or less leakage. Urinary retention is almost always temporary. We put it, if you can't pee after surgery, in fact, it's sometimes a good sign that we got the sling tight enough. And we'll put it in a catheter for a week, take the catheter out, and most men will be dry after that. I've seen one patient in 9 years that needed a second operation because their sling was too tight. Post-operative pain is almost always temporary. Irritation at the wound site, foreign body response. There's so much tissue around the urethra in the male sling that the erosion issues that you hear about on the commercial for women with mesh is very, very rarely an issue in men. The artificial sphincter does have side effects. Device malfunction or failure may require revision surgery. I tell men that have an artificial sphincter that they're probably going to have another operation in the next 10 years. That's part of the deal for the heavy leakers to get dry. If you've had radiation, you are a candidate for the artificial sphincter. Probably half our patients that get artificial sphincter have had some radiation therapy in addition to the prostatectomy. So it can be safe. We generally want to wait 3 to 6 months after they complete radiation before we'll do the surgery. Erosion of the urethra in the cuff area is usually after a long period of time. The constant pressure in the urethra wears it down. If that were to happen, the device would get removed, leave a catheter in for a couple weeks, let everything heal, and you can come back in 3 months and replace the artificial sphincter. But that's usually after many, many years of using the device. Urinary retention is pretty rare. Infection, pain, and soreness, any artificial or foreign prosthetic device is subject to those issues. But I will tell you, some of my happiest patients are artificial sphincter patients. To go from 10 pads a day to 0 or 1 pad a day is life-changing for men with side effects from prostate cancer. So there are a variety of options. There's more than just coping, okay? The short-term options, the pads and all that, if you really add up how much you're spending on pads, it can be $3,000 to $5,000 a year on pad usage, which is far less than the insurance deductible on any of these procedures we're talking about. They can be uncomfortable. They can make you self-conscious about smell or showing through the clothes. A sling or an artificial sphincter could be a permanent solution for your stress incontinence. Talk with your urologist, especially one versed in prosthetics, such as myself or someone close to you. And that concludes our presentation. One thing a lot of people ask me about out-of-pocket costs. I would say a large portion of our men don't pay anything out of pocket, especially Medicare with a secondary. If you have questions about what the costs are, you can ask your insurance company in a facility, outpatient, and our office can certainly supply you with the codes to get your exact out of pocket from your insurance companies. Medicare covers both of these procedures. Or all of these procedures that we discussed, the penile implant, the artificial sphincter, and the sling, and with varying different insurance coverage on the injections, the vacuum, and the pills. Well, thank you guys very much for joining me. If you have any questions, please write it in the comments or reach out to us via the office. Our office phone number is 405-340-1279. You can reach us via our website at www.urologyoklahoma.com, or you can follow us on Facebook or Twitter. Thank you very much for taking the time to learn more about ED and stress incontinence.